Okay, bacterial keratitis. Description. Bacterial infections of the cornea are acutely sight-threatening and, if left untreated, can rapidly progress to marked stromal loss and even perforation. Bacterial keratitis almost always occur in the presence of a significant risk factor such as contact lens use, especially with poor lens care or extended wear, and even the high oxygen transmission lenses worn on the extended wear basis represent an increased risk of developing bacterial keratitis. The most common causative organism is contact lens related bacterial keratitis is Pseudomonas aeruginosa, a bacterium that is not notable due to its ability to spread rapidly and lead to severe inflammation and tissue damage. Other risk factors include a poor ocular surface, lid disease, prolonged topical steroid use, lacrimal drainage system dysfunction, corneal abrasion, epithelial defect of any cause, and recurrent corneal erosion syndrome. Symptom: Patients usually present with increasing photophobia, lid swelling, blur, and a watery discharge. They also frequently experience a foreign body sensations and increasing pain. Although wearing a contact lens may mask symptoms, occasionally there may be a mucopurulent discharge from an associated bacterial conjunctivitis. Signs: There are several acute inflammatory signs within the cornea itself, with an inflammatory infiltrate, stromal edema, stromal loss, and keratitic precipitates. The anterior chamber also displays signs of inflammation with cells and flare, and frequently a hypopyon and synechia. These are not usually due to infections within the anterior chamber, but rather are signs of steroid inflammatory secondary to the inflammatory mediators and bacterial toxin released within the cornea. Investigations. Whether all microbial keratitis need to be thoroughly investigated for the curative organism is debatable. Therapeutic. Even prior to bacterial stains and culture results, treatment with broad-spectrum bactericidal antibiotic is commenced. Current practice is either monotherapy with a ciprofloxacin or dual therapy with fortified ciprofloxacin. Jobs are commenced hourly, day and night, usually for a minimum of 48 hours. The patients may be admitted to hospital if compliance is thought to be an issue. Although most microbial keratitis is treated within the community, not requiring hospitalization. Once a good clinical response is observed, the antibiotic can be gradually decreased to 2 hours by day, 4 hourly by night for 2 to 3 days, then QID usually for a week. Antibiotics are not withdrawn because of the staining result due to the risk of polymicrobial infections, but may be added. If unresponsive to treatment, antibiotic may be changed as a result of sensitivity results, although if a good clinical response is observed, antibiotics are usually continued if the organism is found to be resistant to the antibiotic on sensitivity testing. This is probably explained by a higher drug concentration at the site of infection than is used for sensitivity testing. The use of topical steroid in the treatment of bacterial keratitis is controversial. They are not used initially, but may be added after appropriate clinical response is noted to reduce inflammation and thereby the degree of scarring and epithelial defect. Dosing: ciprofloxacin or ofloxacin or moxifloxacin Q1H day and night for 2 days, followed by Q2H day and Q4H night for 3 days. In the presence of a good clinical response, then QID for 1 week, or at least until closure of any epithelial defect. If indicated, fluoromethanol acetate is added BD for 2 days followed by QD. Usually commence on day 3 or 4 following a good clinical response to treatment. Review. To follow the response to treatment, it is best to follow the size, density, and age of the corneal infiltrate. With effective treatment, the initial response, usually observed over the first 1 to 2 days, is a stabilization of the infiltrate. The infiltrate will then decrease the size and density, and the edge will usually become more distinct and round rather than infiltrative of the surrounding tissue. The hypopyon may increase in size over the first 1 or 2 days of treatment, probably as a response to the liberation of antigen from dead and dying bacteria. It is then usually becomes more distinctive and gradually resolve over a few days to a week. The epithelial defect may take days to a week or 2 to fully heal. Following resolution of the infections, an area of focal stromal loss from tissue digestion is often present at the site of the maximal inflammation. This is especially so with the gram-negative organisms such as Pseudomonas that release lytic enzyme including collagenase.